Good afternoon, everyone, and welcome to the second day of Kidney Action Week. My name is Dr. Delphine Tuot. I'm an associate professor of medicine in UCSF's Division of Nephrology at the Zuckerberg San Francisco General Hospital and Trauma Center, and the associate chief medical officer for specialty care and diagnostics at the same hospital. I have the pleasure of acting as your moderator during this interactive session entitled Life with In-Center Dialysis. So before we start, let me give you a little bit of background about myself. I'm a practicing nephrologist who specializes in patient communication and health literacy. My research focuses on the development, implementation, and evaluation of interventions that improve communication, improves patient self-efficacy and self-management for kidney disease, as well as health system innovations that translate evidence into practice for safety net populations as they are at greatest risk for CKD-associated morbidity and mortality. And while I can provide insight from the provider perspective of the benefits and barriers to in-center hemodialysis, I'm so grateful to be joined today by a panelist who has been a registered nurse for 17 years, 15 of them working with patients going through dialysis, as well as 2 other wonderful RNs who can speak to their own experiences working in in-center hemodialysis units and how that has impacted their lives and the lives of their patients. So before we get started, I do want to encourage all of you to join the conversation wherever you may be logging in from. We will have a Q&A at the end of our time today, but you do not have to wait until then to ask your questions. Drop your comments in the window next to or below the Facebook live stream or in the chat box below if you're here with us on the Kidney Action Week website, and we will try to answer as many of these questions as possible. Now, let me introduce our experts for today's session. This afternoon, I have the pleasure of joining Christy Keller, Carolyn Evans-Howard, and Shanice Lattimore from Iredell Health Systems. Welcome, everybody.
Hi.
Hi.
So let me start by introducing our 3 wonderful panelists. Christy Keller is the Associate Director of Hemodialysis at Iredell Health System. She comes from an Air Force family. She moved to Statesville, North Carolina at age 13 and has lived there ever since. She's wanted to become a nurse since childhood, attended Mitchell Community College in Statesville, North Carolina, earned an associate degree in nursing in 2005. She started her career at Forsyth Medical Center in Winston-Salem, North Carolina in intensive care, and then moved to the outpatient dialysis nursing in 2007. She became a certified dialysis nurse in 2010, worked full-time as an outpatient dialysis nurse at West Iredell Dialysis Center for 12 years as the charge nurse before taking on the role of assistant director at Iredell Health Systems in 2019. She finished a bachelor's degree in nursing at Gardner-Webb University in 2021 and is currently pursuing a master's degree in nursing administration at Gardner-Webb and hopes to graduate later this year. She adores dialysis nursing and continues to work PRN at the outpatient clinic in addition to her hospital role. She also is employed by Mometrix, where she is currently writing new study materials for nurses looking to sit for their certified dialysis or certified nursing, nephrology nursing exams. Christy lives in Statesville, North Carolina with her fiance, their 2 children, and their beloved dog, Sonic. So welcome, Christy.
Thank you.
Carolyn Evans Howard is a native of Fort Mill, South Carolina. After graduating high school, Carolyn attended Winthrop University, where she earned a Bachelor's of Science in Education. She decided not to pursue a career in education quite yet, but to become a flight attendant for one of the 4 major US airlines. And after traveling the world, she decided to settle down in Keene, New Hampshire. While there, she completed odds and ends jobs, met influential mentors that guided her career path towards nursing. In support of her personal relationship and now husband, Carolyn moved south to Moorville, North Carolina. She attended Rowan Caribas Community College, pursued 2-year degree in nursing. And while in school, she began working as a certified nursing assistant in the dialysis unit. In December of 2002, she graduated with honors, accepted an RN position with the dialysis unit at the community hospital, and she is now pursuing her master's degree in nursing education with a graduation date of December 2022. Working in the dialysis unit afforded her opportunities to learn and advocate for the best quality of life for patients living with end-stage kidney disease. And Carolyn currently lives in Statesville, North Carolina with her husband, their 5-year-old son, and her dog, Cooper. Welcome, Carolyn.
Thank you.
And last but not least, Shanice Lattimore was born and raised in the small town of Statesville, North Carolina. She attended West Iredell High School and graduated in 2006. She had her first child that same year, worked in a factory until she realized that she needed to go back to school. She then decided to pursue a career in nursing and attended Mitchell Community College. In 2012, she received her associate degree in science, moved to Charlotte, North Carolina, and began her career. She started working at Fresenius Kidney Care in an outpatient clinic and trained to become a dialysis nurse. She worked there for 2 years, felt that she needed a little bit more hospital work, and so worked in a medical surgical ward as a new nurse. Worked in Atrium Health as a bone marrow transplant nurse, where she gained quite a bit of knowledge and experience. She became pregnant with her 2nd child and went back to pursuing dialysis nursing. Upon her return, she realized that dialysis was the place for her. And she's been able to gain experience from both inpatient and outpatient dialysis settings. She's worked in companies such as DSI, US Renal, Novant Health, and in the VA. And in 2019, she moved back to Statesville, North Carolina, and settled in with her 2 boys. Since then, she's continued to work in dialysis as an inpatient nurse at Iredell Memorial Hospital. So if you're joining us now, welcome to Life with In-Center Dialysis. If you have any questions, please do type them in the window next to or below the Facebook Live video or in the Q&A box below. We're going to have a great discussion today, and I assume we'll have many questions to answer. So let's go ahead and get started. With that, I'd like to turn it over to Ms. Keller to provide an overview of the stages of kidney failure and what she and her colleagues do to help patients with kidney disease at their in-center dialysis unit.
Hi. So I'm Christy. So a little bit about us as the health system. So Iredell is a 247-bed nonprofit community hospital. We are one of the few left in the United States that is a small hospital-owned dialysis unit. So we are completely independent. We are not affiliated with Fresenius. We are not affiliated with DaVita. We are not affiliated with anybody. We're just our own little acute unit here. We have 5 registered nurses, 1 licensed practical nurse, and 2 certified clinical hemodialysis technicians. CCHTs or techs might be a term you're more familiar with. Next. Okay, so the stages of kidney failure. As you may or may not know, there is 5 stages, 1 through 5. These may be referred to as CKD, chronic kidney disease, or ESRD, end-stage renal disease. Stage 1 is very mild damage to the kidneys. You still have 90% of kidney function remaining. And in stage 1, as well as stage 2, there will be no symptoms whatsoever. You would not realize on a physical level. You won't feel any different. Stage 2 would be a mild damage, but they're still working well with 60 to 89% of your function still remaining. So everything is still going business as usual in your body. Things are going okay, but there's some damage sustained and you may or may not have any idea. If you've had some lab work, then sometimes they can catch that. But there's people walking around all over the place that have no idea. Stage 3, you've gotten a more moderate damage to the kidney. 30 to 59% of kidney function is still remaining. So body systems are still operating just as they should, but lab work is going to definitely pick up on this. Most of the time, you're still going to be asymptomatic. Stage 4 is severe. At stage 4, you've got 15 to 29% of your kidneys still functioning. So while it's still able to do enough to keep you alive, at this point, people usually start becoming symptomatic. You may start feeling weak, tired, things like that. Lab work is definitely going to be, showing red flags if you were to have that done. Usually by the time that you have hit stage 4, the damage is so severe to the kidneys that it is no longer reversible. Stage 5 is what is called ESRD, and that is the final stage. So that is dialysis. Once you hit stage 5, then you have to start dialysis. That is the most severe form of damage to the kidneys. Also, anyone that has had kidneys removed, you would still be considered stage 5. You have less than 15% of kidney function remaining. So though you could still make some urine, the urine is not really any good, so to speak. So it's not filtering out your body like it should. So you will have various electrolytes and toxins will kind of start to build up in your body. At this point, you are usually very symptomatic. Can go to the next one. Okay, so if once you get to stage 5, you're probably going to go on some sort of renal therapy. So renal replacement. Your waste products are going to start building up in your blood. You may start having high blood pressure, not enough red blood cells, which is called anemia. That usually can leave you feeling weak and feeling really tired. You can get bone disease, heart disease. Potassium can elevate or sometimes be low, but more often we see it very high. Your phosphorus will become very high. That can cause a lot of itching, feeling, and a metabolic acidosis, which is just the buildup of acid in your bodies because your kidney regulates that. So when it can't anymore, then all this acid begins to build up. You will probably start feeling weak, tired. You'll swelling a lot of times in the arms and legs, feet, face, sometimes abdomen. You may start noticing that you're making less and less urine. You may still make some, but it may be a lot less than you used to. It may be none at all. Headaches are common, a lot of low back pain, cramps to your muscles, a lot of nausea or vomiting we see pretty frequently. Little to no appetite. Your skin may sort of change color. You may get sort of a yellowish color, very pale looking, and you may even have trouble breathing. So this is the point when you're going to go on hemodialysis, or you could go on peritoneal, you could go on home hemo, but still in the United States, 85% of people are going to start out on hemodialysis. Most people are going to stay on hemodialysis. So to find out what stage you're in and to get here, your doctor's going to order all kinds of tests, some blood tests, tests on your urine. They will be looking at everything before a decision like this is made, that you have gone into full ESRD. Ideally, you should be seeing a nephrologist when you get to stage 2, but that doesn't always happen. And that's okay too. But if there's anybody that knows that you have like a low level of kidney failure, you've been told stage 2 or stage 3, make sure that you are seeing a nephrologist. I really can't stress that enough. If you're not, ask your primary doctor for a referral to one. And dialysis is going to be, if your treatment team decides that that's what you're going to do, it's going to clean your blood when your kidneys can't anymore. So you can also have a kidney transplant, which is a surgery that will give either a live or a deceased person can donate a kidney to have a transplant. That's unfortunately not as easy as we would like it to be, and not everybody is even going to be eligible for a kidney transplant. So hemodialysis remains the most common. And so we just wanted to kind of talk about that today and what that means and what life is like typically for, most of our patients. So that's all I have on that part. Do you have any questions on that?
I think there are a couple questions that are coming in about dialysis access. So I thought perhaps you could go into those slides and then we can move forward from there.
Okay.
Next slide, please.
I think you need to go back one. Oh, that's the first one. Okay.
Okay, well, before you can begin dialysis, you will need minor surgery to get a vascular access. This is a way for your blood to flow in and out of your body to the dialysis machine. At the start of each dialysis treatment, a dialysis technician will place 2 needles in your arm using the vascular access. Your blood will flow through 1 needle of your vascular access to the dialysis machine, and then from the dialysis machine to your body through the other needle. There's 3 different types of accesses. One of them on the screen right now is the catheter access. Catheters can be placed in the femoral or in your chest. It's a temporary access or emergency access. If they stay in too long, there is a high infection rate, and they're used only when no other access is usable. Next slide. There are 2 types of catheters, the non-tunneled venous catheter. This is emergency access. This is normally called an IJ. It's intended for short.
I'll go back.
Can you go back a slide? It's intended for short-term use, 3 to 5 dialysis treatments or approximately 1 week. The tunneled venous catheter is the catheter that is placed in the chest or in the femoral vein. Is used for a longer length of time, but not recommended for long-term use. And the fibrous cuff holds the catheter in place. And that's why it's called a cuffed catheter. Next slide. The arteriovenous fistula, or the AVF, is a minor surgery. The surgeon connects one of your arteries and veins together to create an AVF. The AVF must mature for a minimum of 6 to 8 weeks after placement before it can be used. This has a lower infection risk and lasts longer than other access types. This is the gold standard of dialysis accesses.
Can you see that? Can't see it on that screen.
The common sites for AV fistulas is brachiocephalic, brachiobasilic, radiocephalic.
Great. I think I'm going to chime in here with one question from the audience. Thank you for explaining those different vascular accesses. The question was about when somebody starts dialysis, what is the best access for them to have when they start? I think is question number one. And then after that, can that dialysis access be changed?
That's a great question. So the best is a fistula if time permits. So if you know that you're going to be on dialysis, your nephrologist has already talked to you about this, and you know that it's not yet, but it's 100% coming, then sometimes patients will have a fistula put in preemptively so that it can be ready for use when the time comes. But most people, I would say, that is not the case. And so most people are going to be started with one of the accesses Carolyn was talking about in the chest or in the femoral vein, one of the catheters. But either way, yes, they absolutely can be changed. Most of our patients start with a catheter and have the fistula placed, and then you can use the catheter while we wait for that fistula to mature, because that does take 6 to 8 weeks after the surgeon places that for you. So in the meantime, we can use the catheter. Once the fistula is matured and working, then the catheter can be removed.
Great, thank you. And then piggybacking off of that, if say a fistula was created ahead of time, which is great and what we all hope for, but unfortunately it's not actually working on the day that dialysis starts, or it doesn't mature well, what are the other options at that point?
Sort of depends. We can either consult with vascular surgery, can come and look and see. Sometimes they can do what's called a fistulogram, where they go in, and if there's maybe a space in there that's narrowed, then they can kind of roto-rooter it out, basically, is sort of how we like to say it. And it can be to make it usable. If it has not matured, then usually a temporary catheter would be placed at that time so that we can start with that while whatever needs to be done. If the fistula did not maybe mature and you have to have a new one placed, or if maybe it just needs like a minor surgery on it to get it to where it's working again. In the meantime, we can use the catheters until we get a fistula going for you.
Great. And another question about that is, if a fistula does not mature well, does it need to be removed if it can't be used actually, and a new fistula or a new graft needs to be placed?
That's very rare that they remove them. Usually when the surgeons start, they will start low so that they have room to move up, because sometimes they do fail over time. Fistulas have the longest life of any kind of access. I have had patients that have had a working fistula for over 20 years, but most of the time, someone's lasts a long time, but it's not going to last that long. So they usually will start, if possible, lower on the arm, and then they move up for that reason. So if you start up here, then you have nowhere, you can't go back down, if that makes sense. So they would start and put an access low in the arm if possible. Then if that were to fail, then they can move up. But it's rare that they would actually take it out. Usually they do what's called ligating it. So they go in and do a surgery where they sort of tie that off so that it wouldn't work anymore. And then after that, you would not have another access normally created in that same arm. They would probably put it somewhere else, maybe in the other arm. Sometimes they do put them in the thigh. Sometimes they put them here across what's called, in our terms, as a necklace, where they put it kind of across the clavicle. So there's a lot of different options to use, but it's rare to take them out, though I have seen grafts removed if it were to be infected or something like that, but it's very, very rare that that actually happens.
Great, thank you so much for that expertise. We have one other question that this delves right into, and that's about preventing infections. How can we as patients prevent infections in both the catheters and the fistulas or grafts? Do you have recommendations or pearls of wisdom?
I would say the catheter, the number one thing we like to tell people is, please do not take a shower with that catheter in. Nobody wants to hear that, and nobody listens to that. So I know y'all are taking showers anyway, but even if they'll say, well, I'm not going to get it wet, I'll leave that part, over to the side. The moisture from that shower, the steam is getting that dressing all up. that catheter goes straight directly into your heart. So having that moisture, that steam, I mean, that's going to breed bacteria around here. So that is my number one. Please, please do not get in the shower with it. I know it's irritating. I know how difficult that is, and everybody wants it out so they can take a shower, but we really need you to sponge bathe and not get this area wet until that catheter comes out. That is the number one way. If the dressing is loose, put something on it, at home to reinforce, maybe some tape just on the side. Please do not try to change them yourself. If it is to be, if say today is Tuesday and my dialysis day is not until Thursday, if you need, and it's really loose, call them over at your center tomorrow. Somebody can come out and change that for you, but we don't like you to change them yourself because there's a very specific way that we do that to avoid getting any germs introduced to that area. As far as a fistula or graft goes, not a whole lot because those are under the skin. So when they're first placed, you may have some staples, you may have some stitches, something like that on the top. Just keep it clean. If you need a dressing on there, your surgeon will let you know that. Most of the time, just open to air is totally fine, just soap and water. Anything that you notice needs to be brought to our attention or your nephrologist's attention as soon as possible. If you spike a fever, if your arm is red, if it is hot, those kind of things, we need to know about it immediately. You can always go to the emergency room if your center's closed and it's after hours, but those are the kind of things. Don't think like, well, maybe I'm just catching a bug, something like that. Especially anytime there's a fever, we need to know about it. So please let your treatment team know as soon as possible if you have any of those kind of symptoms. Itching is very normal around those catheters. That's not necessarily a sign of infection, but if you see it getting red, anything like that, please make sure somebody looks at that as soon as possible. And those are probably the easiest tips to prevent any kind of infection in there.
Great. Thank you so much. Such helpful words of wisdom. I can tell that you guys have had a lot of experience with this. So perhaps we can move on now to the next slide and talk a little bit about how folks feel on dialysis. I think you can go to the next slide, please. Perfect.
So a lot of people wonder when will they start to feel better. A lot of patients do not realize how bad they've been feeling before they start dialysis. Patients are often told, you will feel so much better after dialysis, although this is not immediately true for everyone. The way it takes a while for toxins to build up so much that symptoms begin, it takes a while to regulate electrolytes again. Next slide. Though most people feel better after starting dialysis, it is not usually instantly. Most patients feel slightly better as time goes on, but do not be discouraged if you do not feel better immediately. You have to give it some time. You have to limit yourself on fluids. Kidneys help balance the water in your body. When the kidneys do not work properly, fluid can build up and cause many problems such as shortness of breath and swelling. Most dialysis patients are advised to drink 32 ounces a day plus the amount of urine output. Talk to your dialysis team about what is the right amount for you.
And just to piggyback on that 32 ounces, a lot of people get too caught up in that. That is not necessarily correct for everybody. That's why we really do advise you to talk to your nephrologist, talk to your team. If you're in the center, talk to your dietitian about it because it's 32 ounces plus urine output. So if you're still someone that makes urine 2-3 times a day, then 32 ounces may not be enough. That needs to be in addition to however much urine output you have. So, and like I said, it's different for everybody. That's not set in stone necessarily. That's a general guideline. So it's really important to talk to your dietitian and just, collaborate with your treatment team to find out what's the best fluid level for you personally. For ideas on things to limit it, thirst is a big problem for dialysis patients. 32 ounces is not much at all. So it's not easy for anyone to follow that. And fluid is fluid, so it comes in all kind of forms. It's not just what you're physically drinking, like this bottle of water. It's anything that is liquid at room temperature. So soup, jello, ice cream, salad, all of that is water. And your body can't necessarily take that much, but it doesn't mean that you're any less thirsty than you were before. So we do recommend trying to, as ways to kind of help get used to that fluid restriction, because that's really, really hard for people, is the fluid restriction. Try to drink out of small glasses, like things like this, like small water bottles, even smaller than this. Sometimes we say no more than 6 ounces, smaller cups, smaller bowls. You can put lemon in a cup of cold water, and that'll kind of help with that dry mouth feeling that a lot of people complain about. Eating something cold or frozen fruits or something cold sometimes can help that. You can suck on hard candy, sugar-free gum, ice cubes. Watch the ice cubes though, because people can get carried away with that. But things like that will kind of help with that thirst mechanism. I would say most important is to really watch your high sodium foods. Salt is everywhere. So it's a lot of people think if you don't add table salt to something, then you're good to go, but that's not necessarily the case. Canned foods, any kind of processed foods, processed meats are very, very full of salt. So that can make you really, really thirsty, and you just don't realize how much salt you're actually eating. So, on this next slide, the picture there shows like go back. That picture there of that salt shaker shows the salt in your processed foods from your grocery store. That's, what does that say? 68% of the salt that you're really eating. So as much as you think that you're adding, that's only 13% of your added table salt. 13% or 15% is found in your restaurant foods. Almost everything is in processed, prepackaged, canned foods. So those really, really need to be restricted. All of that is just going to make you more thirsty, and it's harder for you to control your fluid intake. And any kind of convenience food falls into that too. Things that are already packaged, already made. Lunch meats are terrible for dialysis patients. Ham, pepperoni, salami, these are all full loaded with sodium. So it might occur to you to try a salt substitute. We ask that you please do not do that without speaking to your dietitian. A lot of them are loaded with potassium, which is not something that people would necessarily know. So people think that they're really, doing well by using a salt substitute, but that can really spike up your potassium without you realizing it. So before trying anything like that, definitely make sure that you're talking to your dietitian about it to make sure that what you have is safe for you to use. Next slide. For an easy way at the grocery store, if salt is in the first 5 ingredients, this is not a good choice. Again, in almost anything that's canned, ask your dietitian how much sodium you should be shooting for a day. So at least you have a guideline to go by. That doesn't necessarily mean that you're really going to be able to stay within that guideline. And that's true for pretty much everybody, kidney patient or not. But anything that has more than 240 milligrams of sodium in a serving is really too much. So try to really limit or stay away from those if you can. And if there's more salt than there is calories in the serving, that's a quick way to look and just see if it says, 180 of salt and there's only 80 calories, then that is definitely not a good choice. So, just kind of train yourself to start paying attention to these sort of things at the grocery store to just sort of help you get where you need to be more conscious of the salt that you're taking in. You can go on to the next one. These are some resources that are really great that talk about low sodium foods. So these are from thekidneyfund.org. And there's some low sodium recipe examples of low sodium mayonnaise and low sodium deviled eggs. So try to check those out. Those should help a good bit with, just learning to limit that salt intake, just getting on that track. And you can go on to the next one. And one of the questions, we get a lot of questions about dry weight. So your dry weight is the weight at which when your blood pressure is under control, you're not swollen, and you're not feeling symptoms during treatment. So this is when your body's at its homeostasis, and that is what we consider to be the dry weight. If you are having cramping, you're feeling dizzy, your blood pressure's dropping, you're feeling really washed out and exhausted after or between dialysis treatments, then sometimes that indicates that your dry weight may be too low. And that means that we're trying to pull more fluid than you have. But that's not always the case if you have any of these symptoms. But if you're feeling any of these things during your treatments or between your treatments, you definitely need to be letting your team know so we can start looking and see, is that something that we need to be increasing? Usually as you start to feel better, once you start dialysis, then your appetite will start to improve. And so we're hoping that you will generally gain some body weight back, if you had lost a lot before. So when you gain regular body weight, that's not the same thing as fluid weight, and we may need to increase it. But on the other hand, if you are having a lot of swelling, like your feet and legs are swollen, your blood pressure is getting really high, you're having trouble breathing, then it may be that you've got fluid around your lungs and, around your heart, and we may need to increase your draw weight, meaning we'll pull more fluid off of you. Your nephrologist is the one that actually sets the draw weight. So they decide what that weight should be. But no different than people without kidney disease, body weight fluctuates all the time. So adjustments have to be made frequently. That is common for everybody. So it's perfectly normal for, if your dry weight is 150 pounds, let's say, that, in 6 months, it's not still going to be 150 pounds. Maybe it's 152, maybe it's 148, but these things go up and down. So it's just something we kind of have to play with all the time. But if you're noticing that you're having trouble breathing when you lay down, that you're swelling, your blood pressure seems higher, these are all things you need to let your treatment team know. And on the same token, if you're feeling really washed out, you're exhausted, you're having a lot of cramping or feeling dizzy or sick at home, you need to let us know that too. Maybe we need to increase your dry weight. So it's something we kind of have to up and down for, all the time. It's never for sure that it'll always be at this one weight. So that's just important to know. But that's something you have to let us know on your symptoms so we can try to help you from our side. Next slide. And last, we wanted to talk about complaints, wanted to address complaints. Can I complain? You don't like your center, you're unhappy in your center, you don't feel that a particular nurse takes good care of you, a particular technician, or whatever the case may be, you absolutely have rights. So if you don't feel that you're getting appropriate care, you can definitely do something about it. I would always recommend first is, speak to, your treatment team, the people taking care of you, your nurses or techs, whoever they may be. You can ask for the charge nurse, and then just continue to go up the line, ask for the nurse manager or the facility administrator. They're called FAs in some places, or the social worker. These are usually going to be the easiest way to resolve an issue that you have, is to let these people know, your managers in the clinics, or your social worker. And 99% of the time, whatever problem you're having, they can absolutely help you. If you feel that that has not gotten you the appropriate help that you need or fix the problem, every region in the United States has an ESRD network that can help you. So here in North Carolina, we are Network 6. Any patient, any family member, any patient representative, advocate, professional, or state survey agency can file a grievance. So this will be probably in the lobby of your dialysis center. they have to have this as required by law, that they will have this posted where you can get in touch with your network. So if you need to file a complaint for things like that, you absolutely have those options. Those are your rights. You can do it by phone, you can fax it, you can mail it, and somebody will get on there, speak to you, and can address things. Again, I always recommend try to resolve it within your facility first, because that's just usually more likely to get you the results that you need. But if you feel like something is wrong, or if this is not even you, this could be your mother, this could be your friend, you absolutely have these options. We don't want people to think if you just don't feel like you're getting appropriate care that there's nothing you can do and you're just sort of stuck in at anyone's mercy, because that's absolutely not true. The network definitely will respond to you. They will respond quickly, and they will definitely look into your complaint and do something about it. So please keep in mind that those options are 100% open to all dialysis patients, their families, friends, employees at the center. So we just want to make people aware that those options are definitely out there. So please use them if you need to. Next. That's it. And these are some links. There's the grievances and concerns. That's got the ESRD networks, the patient grievance toolkit, because you can also file a complaint with your state Department of Health. And so there's also a Spanish version if you need it, and that would tell you exactly what to do step by step to file a complaint, file a grievance, or just to get in touch with your network. So please use those if you need to. Those are 100% available.
Great, thank you so much. Always good to know about ways to advocate for ourselves, for our patients, for our loved ones. We do have a couple additional questions coming in, kind of harking back to some of the slides that you guys just went through. The first one is about feeling sleepy. I think there's a recognition that people do start feeling better after starting dialysis, slowly but surely, as you mentioned. But why is it that people are so tired after dialysis? Do you have any thoughts about that?
Dialysis is hard on the body. It does wipe you out. We have lots of complaints about, I would say most people say after, especially at first, that they go home right after and take a nap. So, you have to remember that you've got to be easy with yourself, I think is a lot of it. I think people expect, well, I'm going to feel better and everything's going to be just like it was. But, you've got to cut yourself a break too. It's not easy to live with kidney failure at all on any type of dialysis, any type of renal transplant. None of it's easy. So remember to cut yourself a break, and that your health is not as good as it necessarily once was. And so you need to take those opportunities to rest when you need them. Don't try to do everything. And, people will understand. If they don't, then we always say, well, just call me and I'll be happy to explain it to them. If, people say, oh, well, you're lazy, you're not cleaning your house, just let them call me and I'll be happy to discuss it with them. But, that's very normal. Where toxins sort of build up and we're, pulling all this out of you. It's a lot. It's really taxing on the body. So it's very normal to feel tired afterwards. Sometimes that goes away after a while. Sometimes it doesn't. There's really nothing we can guarantee you either way, but, it just wipes you out. I would say, when you say that's usually what they say is it wipes me out sometimes. So we just really recommend you take that rest that you need. If it wipes you out, go home, lay down, rest until you feel better.
Great, thank you. I also wonder whether sometimes feeling particularly exhausted after a dialysis session might be because someone's dry weight might be a little too low. And so we, as nephrologists, as technicians, as nurses, might be trying to pull off a little too much fluid. You mentioned this a little bit before, but can you walk us through how does one increase a dry weight? Who does the patient need to talk to increase the dry weight? And why might we do that?
If you feel like your dry weight needs to be increased, and a lot of patients do, if you're feeling that wiped out feeling every treatment, then, you definitely need to let us know. Let your your techs know, let your nurses know at your center. If you see your nephrologist first, let them know. But usually you're probably going to see your nurse before you're going to see your kidney doctor. So let your nurse know, and your nurse will speak to your doctor about it. Tell them about what kind of symptoms you're having. And then ultimately the nephrologist decides if a dry weight increase, if they think that's the issue, or if they think that it's something else. So, that still comes back. That's 100% the nephrologist sets that. But, we can always tell the nephrologist what we see, and, they make the decision based on that and some of the facts we give. So just definitely, I would say, let somebody know. Let somebody in your treatment team know, whoever that may be, your nurse or your kidney doctor, either one.
Great, thank you. We do have a question about diet, and I know we don't have any dietitians on the panel today, but what are your thoughts, and have you chatted with your colleague dietitians about plant-based diets?
Shanice, you want to talk about plant-based diets?
Well,
I can jump in. I know that I've had, they're not easy. I've had some conversations with our dietitians about whether are plant-based diets better for patients? Can they provide a similar amount of protein that we want without too much potassium and without too much salt or sodium? I think in early chronic kidney disease, sort of before dialysis, I think there's this thought that trying to limit a whole ton of protein might actually be beneficial. So moving towards a plant-based diet is probably not a bad idea, but we do need to be careful about potassium. And so I think this is where the team-based care, and we're really working with your dietitian to see what works best for you, is what I would recommend. There is no one diet fits all, just like there is no one dialysis prescription fits all. Does that sound about right?
And, we, as not being dietitians, we can tell you a few of the, absolutely stay away from this, absolutely stay away from that. But when it comes to questions, like this, which are great questions, this is what makes dietitians such an essential piece, I think, for patients with kidney disease, because that's exactly what we're going to do is say, I really don't know, but we're going to get you in contact with the dietitian, or we're going to call them ourselves to consult for things like this, because it really does take the whole team when somebody's got kidney disease.
Yeah, absolutely. I would agree with that 100%. We have another question about monthly laboratory tests, and I don't know if you ladies can comment on that. I can jump in as well, but what are the common lab tests that folks get every month? And are there specific lab tests that they should be asking for?
Mostly you're going to have in the outpatient center on a monthly basis, you're probably going to have a CBC, which is your complete blood count. That's checking your red blood cells, white blood cells, looking for anemia, iron levels, things like that. So you got your iron levels. They'll usually do, it's called different things in different places. Here at the hospital, we call it a renal function panel, might be called a BMP, but that's your electrolytes, your potassium, your sodium, calcium, those kind of things. Those are usually measured once a month. Your KT over V is measured once a month or possibly more, and that is a measure of how well you're getting dialysis. So how much it's actually clearing. We want that number to be 1.2 or above. And what that number is looking for is, it's more complex than this, but a good way to think of it as all the blood in your body needs to be cleaned through the machine 1.2 times during a treatment, is the way I have patients kind of look at it to make it more something I guess we can digest a little bit better. That's one that's usually in there once a month. If there's other tests, it could be, usually those are patient specific. Sometimes diabetic patients will have hemoglobin A1Cs ordered. They usually order things for hepatitis, HIV, things like that are usually ordered on everybody about once a year. That's just to make sure that there's no bloodborne diseases like that have been contracted since the last time. So that's pretty standard. And then for some things, if you take certain medications, then sometimes they'll order blood for that. But usually on a month-to-month basis, it's going to be your complete blood count, your whatever your version of a renal panel is called, BMP, CMP, PTH. That will be done sometimes. That's looking at your parathyroid levels. Most people have those once a month, but that differs, not everybody. And then usually your iron. That would be the most common that are every single month, I would say.
Yeah, great. I think I would echo that as well. I wonder also, how often do you see your patients giving 24-hour urine collections just to see how much residual kidney function they have? Is that common in your center, do you know?
Actually, well, because we're not a center, we're acutes here. So we don't do outpatient, on the norm, but we have a skilled nursing unit here. So patients that are in skilled and need outpatient dialysis, we do provide that service for them. So we do a lot of 24-hour urines, actually, because we have a lot of patients that would still be considered acute where, we're hoping that they may completely recover kidney function or recover enough to come off of dialysis. So we do them a fair bit of the time, I would say, a lot more than you would probably see in a center. But in the center, they do them once in a while. They will have you do a 24-hour urine. Most of the time, it's not necessarily indicated anymore, where they're not necessarily thinking that there'll be a good chance that someone will come off of dialysis. But here in the hospital, we actually do a lot of those, yeah.
Great, thank you. And I think that actually dovetails into another question, which asks about how long are patients on dialysis usually, and what kind of factors do we take into consideration to decrease their dialysis time? Say from 4 hours to 3.5 hours, or 3.5 to 3:15. What has been your experience with that?
Well, that's one of the most popular questions because everybody wants their time cut. So that is all decided, of course, by your nephrologist. So that's who to be mad at if they don't cut your time. But there's a lot of factors that go into that. So you have to consider that someone with normally functioning kidneys are working 24 hours a day, 7 days a week. When you're on dialysis, essentially your kidneys are only working the time that you are here on the machine. So, if you run 4 hours, 3 days a week, then you are getting 12 hours of kidney function versus my 24/7. So more dialysis is never a bad thing. And I think most nephrologists pretty much are on the same page that there's not too much dialysis. So, and I have some that, you're going to run 4 hours. That's their thing. And most are a little more flexible, but there's more that goes into it too. How is your KT over V or those clearance numbers look? Are those appropriate? If you're getting good clearance, they may be able to talk about decreasing your time. It depends on body size. A very large person, you're just going to have more volume that has to be cleaned than a very tiny 80-pound lady. So usually they don't have to run as long as somebody that's just a larger person. So there's multiple factors that go into that. If you struggle with fluid gains between treatments, if you routinely gain 10 pounds between treatments, then you're probably going to have to run a longer time to be able to safely remove that fluid between to keep you healthy. So there's a lot of factors that go into that. But that is probably one of the most popular questions is, I want to get my time cut. I want to get my time cut. I see that she runs 3 hours. How come I run 4? But there's a lot that goes into that your nephrologist is looking at before they make that decision. So, but if you have that question, why do I have to run 4 and Shanice has to run 3? He's not going to comment on why Shanice runs 3, but ask your nephrologist why they've come to that decision to make you run the 4 hours or whatever it is. And, it never hurts to ask them. But any nephrologist will definitely tell you why you need to run X amount of time, or why you need to come an extra day. They won't mind at all to tell you exactly why, because they put a whole lot into figuring out what the appropriate time is for you.
Great, thank you. And another question is about how do folks stay busy while they're on dialysis? I have patients who are on dialysis for 4 hours, 4 hours, 15 minutes. And it is that way because that's what's best for them. And they understand that and they need that, but they have a hard time staying busy during that 4 hours. What have you seen and what might you recommend?
would say most centers have got TVs, so that's always popular. Yeah, music and books are good.
Lots of people go to sleep.
Yes, yes. If you can sleep, I highly recommend that.
Yes.
But then a lot of people are like, it's too noisy or there's too much going on. People bring their laptops and do schoolwork or work for their jobs. We see that a lot of times. A lot of times people just want to talk. They want to talk to the people sitting next to them. They want to talk to us. We do a lot of cutting up with our patients. A lot of times they like to have a good time like everybody. So we do a lot of laughing and whatnot while we're all at it. Because this is what has to happen for you to live a healthy life. I mean, you're going to have to come, you're going to have to do it. So whatever way makes that time pass for you the best, I mean, we're all for it.
Great. Another similar practical question. Do you have recommendations on specific things to wear, particularly as it relates to, say, somebody's access on their arm?
Yes, nothing tight. Anything on, if you have an access in your arm, vascular graft or fistula, whichever it may be, please don't wear anything tight so that we can roll it up over it to get to it. And if you come in with a catheter, a lot of times either something with a very stretchy collar right here or a button up, just so it's easiest for us to get to it without you having to move your shirt all over the place and feel exposed. So then it's more comfortable for you and it makes things kind of run better on our side. Because we do have to be able to see that access wherever it is the whole time. So you can't cover it up with a blanket. We're sorry, we know it's cold, but we really do have to see, where the needles go into the arm or where the catheter is attached at the hub. We really do have to have eyes on that at all times. If that were to come disconnected, you can, you can bleed to death in less than 2 minutes. So that is why we harp at you about it. So please try to at least keep that little area uncovered, but just as long as it's not tight and something warm, usually most people complain centers are cold. So we say, sweatpants, things like that. I would not wear anything white and I wouldn't wear anything new and pretty. It's not the time to show it off. Sometimes we'll tell people just to wear the same thing. They'll have an outfit that they pretty much wear, 1 or 2 outfits and they just wear those to dialysis.
Great. Yeah, I've also seen sort of the zip ups where folks can have a zip up.
Yes, those are really cool. I don't know where they get those.
Which I thought was super cool when I first saw those a couple of years ago. I think you can order them online somewhere, and I'm sure that the dialysis social workers might be able to help you with that if you're interested. Excellent. So I think this has been a really great session with some really practical advice as well as some education about dialysis and about end-stage kidney disease. I wanted to give each of you just a minute to give us your final thoughts. What are, say, 2 takeaways you each want folks to know about in-center dialysis? Carolyn, maybe we can start with you and then work our way.
Let's start with Christy.
I would say, just because you go on dialysis, do not feel like your life is over. I'm not going to tell you that it's easy because it's not. It's a difficult life. There's a lot of restrictions and it's absolutely not easy. So I don't want to sugarcoat it into anything that it's not because, you already know that. But it does not mean that your life is completely over. I've had patients that have been on dialysis over 35 years that are runners, that are still working. Anything is possible. So we just, we want you to keep that in mind, that it's not a death sentence, not at all. You can still live a wonderful life, but there will be modifications, and it takes a while to get used to that. But most people do. And they're still happy, productive people that live a regular life. They just have to modify it in some way. So, also if you're not eligible for a transplant or home hemo is not right for you for whatever reason, those things are okay. There's not one therapy that's right for everybody, and that's totally, totally fine. Your treatment team wants what is best for you. if we recommend home hemo and you're just completely terrified of doing that and you want to be in the center, which we hear a lot of that, that's fine. That's completely fine. We are here to support that. If you really want to do home hemo and you don't want to be in center, we're completely here to support that too. Just, any of those fears or questions, please let somebody know. Your doctor, your nurse, your technician, whoever it is that, you trust to tell these things to, please let them know, because we really do just want to help you. So that would probably be my takeaway.
I think piggybacking off of Christy, the patients, if they could just please speak up if there's something that we could do to make the situation better or help them. We are here to help the patient, and we want to do whatever is possible that we can to help the patient and help them in the situation.
Yeah, and just to add on to that, I would say as well, the patient can still live a normal life, go to work, do everything, just like Christy says, just modifications that you have to do. Don't feel like it's the end of the world. You can still go on vacations and trips, still live a fun, normal life. You just, like you say, some modifications to it.
And if you, especially here in the hospital, it's a lot. Starting dialysis is a lot. So we do not expect you to absorb all this information. So if you don't remember, just ask us questions as they come. If you feel like you've asked that 5 times, that's totally fine. We're used to that. Just continue to ask until you feel like you understand.
Great. Thank you so much. A huge thank you to our panelists and for all of you who joined today. There's so much to talk about ways to optimize dialysis in whatever form that you're getting and ways to help prevent kidney disease as well. If you aren't already, please do follow us on Facebook or send us an email through kidneyfund.org, and you'll be first to know about other resources similar to this one. Also, please check out the agenda for the last 2 sessions of Kidney Action Week, and you can see recordings from the sessions earlier in the week as well. Once I conclude, in about a minute, you'll see a link for a quick survey in green below the video screen. Please take a few minutes to fill it out and tell us how we did. Your feedback is so important to us as we plan future sessions. Stay tuned for our next mini session, Kidney Kitchen, a cooking demo by Chef Linda Blaylock, starting at 5:05 Eastern, 2:05 p.m. Pacific. And then our main session, which is a pre-recorded VHA and AKF coffee chat, will begin at 5:30 p.m. Eastern, 2:30 p.m. Pacific. We will see you then. Thank you, everyone, and have a great afternoon, evening, wherever you are tuning in from.